Ocular trauma scars, remodeling with 5FU. Scarring, as we all know, is a physiological process of healing of the wound. Fibroblasts are the vital constituents of a normal wound healing process. The stages of wound healing are inflammation, proliferation, and maturation. Traumatic scars could be due to mechanical trauma, chemical injury, or burns. They are aesthetically disfiguring, functional loss of eyelid is there, and there are challenges for the oculoplastic surgeons. The various therapies to prevent scarring in these traumatic scars is the use of intralesional corticosteroids, laser therapy, bleomycin, interferon, 5-fluorouracil, imiquimod, methotrexate, and cryotherapy. Various natural therapies were also used in historical time, but they were not so effective. Therefore, the introduction of 5FU was there. It is a pyrimidine analog or antimetabolite. It is irreversible inhibition of enzyme thymidylate synthetase is caused, and this impaired DNA synthesis occurs. It is a scar modular. It decreases the fibroblast proliferation. There is inhibition of collagen type 1 production, and ultimately it leads to reduced scar formation. 5FU only works on cells that are metabolically active and proliferating instead of causing collateral damage to the surrounding cells. It halts rapidly proliferating cells such as fibroblasts, and hence scar degradation is promoted. Additionally, 5FU is believed to hinder type 1 collagen gene expression and the effects of tumor growth beta 1. It is an anti-cancer drug, and it came into medical use long back in 1962. It was used systemically for anal, breast, colorectal, esophageal, stomach, pancreatic, and skin cancers. Topically for the skin, it was used for actinic keratosis, skin cancers, and Bowen's disease. In ophthalmology, it is an off-label use. It was used as early as 1980s to improve the results of trabeculectomy. As eye drops for treating OSSN, it has been used. Subcutaneous injections are used for reducing scars. Its contraindications are severely debilitated patients, bone marrow suppression in pregnant women and breastfeeding women, where we should avoid its use. The side effects, the common ones are local pain, itchiness, burning, stinging, crusting, dermatitis, and photosensitivity, while the rare complications or side effects could be the hyper or hypopigmentation of the overlying skin, telangiectasis, scarring, and ulceration. These various studies were done which promoted its use. Masri most commonly worked on it and performed a study using in skin grafts. It evaluated 19 patients who had skin graft for various purposes, and they were injected a 50-50 mixture of 5FU and triamcinolone. The conclusion was that it led to minimal scarring, high patient and surgeon satisfaction, and there were very few complications. The studies have discovered a dose-related association between 5FU and reduction in keloid fibroblast proliferation and the fibroblast-populated collagen lattice. Another study was done which first introduced 5FU for the treatment of hypertrophic scars and keloids. Horani et al. Reported a 50% median decrease in scar volume in the hypertrophic scars and decreased recurrence rate of keloids after treating with 5FU. Use of intralesional 5FU monotherapy, it achieves good to excellent scar improvement in 45 to 78% of patients. This effectiveness is further augmented with the addition of corticosteroids, triamcinolone, where 96% of patients achieve good to excellent result. And therefore, it was advisable that a combination of 5FU and triamcinolone, it seems to be more effective than either of them alone. The demerits of corticosteroid use were, however, its unpleasant side effects, including telangiectasia, fat atrophy, rebound effects, ineffectiveness, and the painful drug deposits. Another drug that has been commonly used in scar remodeling is mitomycin C. However, it hasn't gained that popularity. It is known to decrease the proliferation of fibroblast, an essential element in the scar tissue. Various studies investigated the efficacy of topical and intralesional mitomycin C for the treatment of keloids and scars. However, the topical application of mitomycin C following shaving excision was safe and effective for the treatment of keloids. However, intralesional mitomycin C therapy aggravated both lesions. We studied the role of subcutaneous injections of 5FU in patients in our clinic. Patients were given 0.4 to 0.6 ml of 5FU injection. At least 3 injections every 4 weeks, maximum up to 6 injections were given. At each visit, the patients were evaluated for redness, swelling, tissue inflammation, atrophy, and pigmentary disturbances. It's a small video. Even a general ophthalmologist can go ahead with giving this injection. The 5-fluorouracil injection, a very cheap injection, all available at a rate of, I think, 30 rupees in the market. We inject lignocaine first in the subcutaneous area where the 5-FU has to be injected, which is loaded on the insulin syringe. And then at the scarred area, you can give at multiple sites this 0.5 to 0.8 ml of this injection at the scarred area. And this injection, it can be repeated after an interval of 3 to 4 weeks. And there's no amount of minimum, depends on the follow-up results, but maximum 4 to 5 injections can be given. The patient interpretation of outcome was determined subjectively by asking if they were satisfied and objectively by comparing the initial and subsequent digital photographs. All the patients were found to be satisfied with the treatment. The scar appeared to be less tight to the patients. One patient, however, developed telangiectasia. These are few patients I would just show you which we treated with 5-FU injections. This patient, you can see the scar has fullness over the scar area and the marked improvement. This patient had lag of ophthalmos when she appeared to us. We gave 3-4 injections, and the last, you can see that lag of ophthalmos was improved. This was another patient with very, very mild cicatricial ectropion on the lateral side, which improved, and we did not need to take any surgery for this. Another patient with medial ectropion. Another patient, these are all patients which we have treated with 5-fluorouracil, and we have found good results in the decrease in the scarring. The softness is definitely there. The patient is symptomatically very happy, and in mild cases of cicatricial ectropion, we may avoid surgery and just treat it with this. Only one patient showed an overlying telangiectasis in this area. Is there any role of 5-FU before surgical correction of cicatricial ectropions? Yes, it definitely helps. I'll just show you a brief few pictures of cicatricial ectropion which we have dealt after giving 5-FU injections. After giving this traction sutures, they are released and a semilunar incision is given over the scarred area. The vertical and horizontal dimensions of the dissected area are measured. Similar measurements are taken 1 to 2 millimeter more than what we have measured over the wound area in the retroauricular area. Graft markings are done, xylocaine is injected, skin incision is raised, skin incision is given and the graft is raised, skin undermining and dissection is done, the skin graft is raised and it is then cleaned of all the subcutaneous tissue. It is placed into position over the defect, suturing is done with the help of 6-0 sutures, and after completing of the suturing, stab incisions are given and a frost suture is applied. So early complications that we saw after skin grafting in the first 2 weeks were wound adhesion, necrosis, infection, bleeding, partial or complete graft failure. However, this did not occur in any of our cases. These are just noted complications. We use 5-FU in patients undergoing surgery for correction of lid ectropion. All these patients of cicatricial ectropion we treated for 2 to 3 months before with 5-FU followed by the surgery. This was one case, the cicatricial ectropion after skin grafting. Another second case, this was the third case of cicatricial ectropion, 5-FU followed by the skin grafting, and this was last case. The take-home message is that 5-FU is an efficient, safe, cost-effective measure. It reduces the cosmetic blemish, and before undergoing lid reconstruction, it is very important. And subcutaneous 5-FU injections, they definitely give gratifying results. Even studies have told that even after the surgery, grafting surgery, post-op patients have also been tried with 5-FU if minimal scarring or tightness of the lid is there, and that time also it has been also found to be effective. So both pre-operative and post-operative for skin scars, it is very important, periocular scars, to give 5-FU. Thank you. Thank you for your kind attention for this instruction course. I hope all of you must have gained a little bit out of it. Thank you, sir.